So with the introduction of PSA into the clinical practice and the fact that some patients who undergo local therapy end up relapsing with a PSA-only progression, hormone treatments, generally androgen deprivation therapy, gets to be used for those patients. Some of these patients end up developing another progression, what we call non-metastatic castration-resistant prostate cancer, which is basically PSA going up, but the scans are not changing, yet the patient has castrate-level testosterone. And so this is an area of unmet need, and in fact, several years ago, the FDA had a panel discussion regarding different endpoints in prostate cancer in different disease settings, and one of the disease settings was specifically this patient population of non-metastatic castration-resistant prostate cancer. I was part of the panel that participated, and we even discussed, in fact, what would be a meaningful endpoint and difference, knowing fully that as the systemic therapy evolves, these patients will be offered opportunities for different treatments, and so how do we judge success? So PROSPER is a randomized phase 3 trial that randomized patients with non-metastatic castration-resistant prostate cancer. Specifically, it targeted patients who we think, based on their PSA doubling time, has poor prognosis with regard to risk of relapse and development of metastases, and randomized them to 2-to-1 in favor of enzalutamide versus placebo. And the primary endpoint was actually metastases-free survival or death without metastases within 112 days from coming off protocol. The results were reported at the most recent GU ASCO, and as I'm sure you have seen, it reached its endpoint, the primary endpoint of metastases-free survival, with close to almost 2 years difference in the median time to metastases.